So I'll just quickly go through the MCQs. But before that, this is a charity program that's run by the Royal Free London on renal cancer. So please do contribute to it if you have a strong feeling about it, but we would encourage you to contribute to it. So coming on to the MCQs, the first question was, which one of the following statements regarding locally advanced renal cancer is correct? The answer was B. The TNM 2000 staging classifies T3B as tumor grossly extending into the IVC below the diaphragm. The next question was, what is the mutation on the gene locus for VHL? And the answer was B, 3P25. The next question was, what's the most common form of RCC in end-stage renal disease? And in patients on dialysis, the patient with papillary RCC, the second highest is chromophobe. The fourth question was, which domain is not present in both models? And that was neutrophilia. Neutrophilia is only present in IMDC. It is not present in the MSKCC model. And the last question was a relatively straightforward question, which is the most common site of metastatic disease after having had curative nephrectomy for RCC. And the answer is lungs. So now I'll go on to the exciting part of my presentation. That's the clinical scenario. So we've got Axel Beck with us, we've got Phil Haslam, Raghunath, and Patricia, Tilly, and Ashwin. So I think we've got a whole cancer board meeting here. So this is the first patient. This is a 40-year-old lady who presented with menorrhagia. She had an ultrasound performed, which showed an incidental right renal mass. She's otherwise a reasonably fit lady with the performance status of 0. Her remaining bloods were normal. She had normal renal function. So she proceeded with a triple phase CT scan. Phil, if I could just request you to comment on this, please.
Yeah, what I can see, you've got a fairly large right renal mass. It looks like it's probably an enhancing mass. There's no pre-contrast, but you did say it's triple phase. Slightly concerned by that right renal vein. I can't really tell whether it's being compressed or whether there's some tumour going into it. I suspect it's just being compressed. Obviously, we need to see all the other images and different planar reconstructions.
Okay, excellent. So we did discuss it in our radiology or in our Euro MDT, and it was an 8 centimeter necrotic right renal mass. There was renal sinus fat involvement and perinephric invasion. The renal vein was clear. There was single artery, and the contralateral kidney was normal. So we staged the patient, and this is what we found on the staging CT. So Phil, would you like to just quickly comment on that?
Yeah, so you've got a couple of small pulmonary nodules. They could be metastatic. You don't know whether they're pre-existing. It could be unrelated to this renal tumour, but obviously they're suspicious.
So we looked at her old scans, and these were new, and we felt that they were likely to represent small volume mets. So if I could now go on to the urologists in the panel, you have 3 options here. It's to do a cytoreductive nephrectomy and monitor the lung nodules. To our oncologist, Karthik, I'd ask, will you consider this patient for systemic therapy followed by cytoreductive nephrectomy? Or would you consider the patient only for systemic therapy? Axel, are you there? Would you like to comment on this, please?
Yes. So this is a classic case of a patient who has, first of all, I would call them indeterminate lung nodules. You're quite right, they are new, but we still don't know what they are. And that is a patient who should undergo nephrectomy, possibly with curative intent. We don't know whether these are mets. Even if they are, let's assume we would know that these are metastatic lesions, then they are so small. We've done a retrospective analysis of 40 patients who were discussed at MDT, and we found that when you do an upfront cytoreductive nephrectomy, that it took almost 1.5 years of most of these patients to proceed to systemic therapy, and that is a time they win without adverse events. I wouldn't personally go for direct excision of these lesions because sometimes it appears that 3 months later there are more nodules, and then you have a different situation.
Thank you very much, Axel. Karthik, would you concur with that?
Yeah, definitely. I would like to concur Professor Axel's view. So Carmen has clearly showed that there's no benefit in starting. I mean, I'm sorry. This is basically a low burden disease, and a patient is absolutely fit patient, and in a good prognosis patients, there is no point in starting systemic chemotherapy. So I would like to probably go ahead with nephrectomy and keep the lung nodules under surveillance.
I'm glad to say that you all agree with exactly what we did. So we did do a cytoreductive nephrectomy. There was a lot of pathology on the specimens, and we chose to monitor the lung nodules. A few months later, the nodules increased in size, but it was a very small increase in size. What would you do at this stage? Karthik, would you give it a further period of monitoring?
Yeah, I think it's now I think it's very clear that it is metastatic because it's growing in size, but it's 3 months and it's marginally increased. So probably yes, I would like to again keep under observation if the patient is asymptomatic.
Okay, Professor Bex, would you any other views on this?
No, I would agree to this. Again, there was this study performed by Brian Rennie on mostly metachronic patients where they observed lesions even beyond progression. So the fact that you have a small increase does not necessarily mean you have to start.
Okay, so we did exactly that. This patient is still under follow-up. And so I just wanted to summarize why we put this case up. Professor Bex in his presentation he spoke about patients with high volume metastatic disease and the consideration of immediate systemic therapy and perhaps cytoreductive nephrectomy later on. But this is a different group of patients. These are fit patients with renal mass with a very low volume metastatic disease. Whilst we don't have level 1 evidence for this, but a lot of us believe that cytoreductive nephrectomy has a role to play in this. So the learning points here are that Carmine and Certime trials, the thing to remember is that the metastasis accounted for up to 40% of tumor volume. All the patients were either of intermediate or poor risk MSKCC risk criteria. It is the IMDC criteria that we use today. And cytoreductive nephrectomy is still an option in patients with low volume metastatic disease with a low risk stratification score. And just because an individual has METs, it does not necessarily mean treatment. Small volume METs can be observed. What you're doing is trying to learn the natural history of the disease and trying to avoid the toxicity of systemic therapy for as much as we can. And as Professor Beck said, there was the study by Rennie et al. In Lancet Oncology, which suggested that the time between systemic therapy and initial diagnosis could be a median of 14.9 months. Would you agree with that, Professor Bex? Would everyone in the team agree with that?
Yes.
Raghunath,
yes,
would you like to add on to that?
Yes, I totally agree with everyone. So I would probably need to go with cytoreductive nephrectomy and observe.
Raman, can I just say something?
Yes, of course. Yes.
Yeah, just one thing to say that often gets forgotten about is the role of ablative therapy in oligometastatic disease. I take the point that there could be metastases pop up elsewhere, but if these prove to be slowly growing metastases with no other disease, they could, of course, be ablated very successfully.
Good. So, would anyone else in the panel like to add to that discussion? Anything more? Okay.
There is a role of even metastarectomy. If solitary MET is there, if it is accessible for surgery, definitely we should go for even metastarectomy.
Okay, fine.
Bhavan, if I can add a point here. So metastarectomy, yes. I would like to probably do if the patient remains symptom-free for another 6 months. So in case you give some more time and if the patient is showing a stable disease, probably that is the time you probably push the patient for metastarectomy. Because here we are seeing a tumor which is slowly growing in size. Probably if I take out the tumor in another 3 months, patient can have few more metastasis in their lung. So probably I think we should give some time before we push the patient for metastarectomy.
Yeah, I would agree to this. I think this is a very important addition to it because we should not forget that most metastasectomy series are almost a self-fulfilling prophecy. So they are retrospective and they compare patients who underwent surgery to those who never made it to surgery. And if you are too aggressive in a situation like this, you might as well end up with the patient progressing very quickly afterwards. Not because you did the intervention, but because you didn't know the natural history of the disease enough. So I think both worlds are right, but I would also be in favor of at least another 3 months of observation.
So in summary, yeah, go on. Sorry.
I think in addition,
Patricia,
you would like to have the lesions a little bit bigger because you want to biopsy, I think, first before you start any treatment to ablate or to start systemic treatment. I think you should prove that this is metastasis from the RCC.
Okay, excellent. So I think in summary, we can all agree that a period of monitoring helps us understand the natural history of the disease, how aggressive it's behaving. And if it's indolent, then perhaps consider metastatic disease. If it's a very aggressive form, then perhaps surgery has little role. But I think that's what we're trying to understand when we monitor these lesions. So I think if everybody is happy, I'll move on to the next case.
Yes, Bhavan.
Okay. So we got the next. I'll now go on to small renal masses. So the next 3 cases are small renal masses. And because we have a number of options with small renal masses, there is also a debate about renal biopsy. There was a question from the audience on renal biopsy. I've actually prepared exactly the same scan for 3 different patient groups, just to start a discussion and see what people think. So the first one is a very fit 52-year-old lady who had an incidental finding of a left renal mass, and she was actually investigated for right upper quadrant pain. So this renal mass is unrelated to this. She's fit, she runs marathons, she's got an ECOG status of 0, her contralateral kidney is normal, she doesn't have any risk factors otherwise, and her bloods are normal. She's got a triple phase renal CT scan. Again, we don't have all the slides here. Phil, would you like to comment on this?
Yeah, well, as you said, it's a solid enhancing lesion. It's very suspicious for a small RCC. Looks very familiar, actually. I'm sure that's one I've dealt with.
I think you may have. So it measures 3.2 centimeters. Patricia, if I could come to you on this, would you biopsy this lesion or would you proceed with treatment based on what we have available?
Well, I think I would discuss with the patient. There is an option to take a biopsy because it is not 100% sure that this is a RCC. So we all know from the Bowes data and also from biopsies during ablations that there has been overtreatment in some cases. So benign lesion can still be the case. So I should discuss that with the patient. And then discuss the several options, the partial nephrectomy or focal therapy, and depending on what the patient would like to have, I would not regularly, routinely do biopsy here. Most of the
Can I just ask? Sorry, Patricia. Can I just follow up to that question? If you do biopsy this lesion and it comes back as benign, what will you do next?
I will discuss that with the patient, and you can consider not to treat. Well, probably, you want to be sure that pathology is really a good biopsy. So oncocytoma, and the pathologist has to be sure that it is really an oncocytoma and not a chromophobic lesion, or that they really had a diagnostic biopsy. Yeah? So you have to be really sure that the pathologist is sure that it is a benign lesion.
So I think the issue with renal biopsies is that there is a concern with tumor heterogeneity, and there is a concern with undersampling some of the renal biopsies. So whilst a negative biopsy is reassuring, we can't always say that it definitely does not mean there's no cancer. So it is a tricky one. I think there is a feeling that if you biopsy all of them, you may reduce your active intervention rates. But there's another school of thought who think that if it's not going to impact on your management that much, how does it? So it's a difficult one. I think, like Patricia says, we've got to discuss the pros and cons with the patient. Anyone else in the panel would like to add on to that?
Yeah, maybe I would like to add that, especially the question around oncocytoma, oncocytic tumors, I think we should not forget that most of these lesions are relatively benign in their behaviors anyway. So even small chromophobe tumors, we did an analysis with the recur database on almost 300 tumors, and you see that those who produce metastasis in chromophobe cancers are those who progress to a size of 7 or 8 centimeters and above, or have sarcomatoid features, which also makes them slightly bigger. So I think even if the pathologist is doubtful, if the patient feels like being observed, then there's not a reason to step down from that.
I'd just like to add on to that, Axel. I presented the outcomes of renal biopsy-proven oncocytomas as a trainee a number of years back in BOUS. And this was our experience as well. We had a very small number of patients, but we followed them up for 5 years. And like you said, tumor kinetics or the growth kinetics were quite slow. And the metastatic potential was not very high. So if it is a renal biopsy-proven oncocytoma, the differentials that we're probably dealing with are chromophobes or hybrid tumors, and they usually behave in a relatively, their growth patterns are relatively slow. Would you agree with that, Axel?
Yes, yeah, exactly.
Yeah. So let's assume that we think this is a cancer. We have a very, very fit patient. This is a 3.2 centimeter exophytic tumor. The options are between active surveillance, ablation, partial nephrectomy, radical nephrectomy, leave alone. If I can ask Ashwin, what would your views on this be, Ashwin?
Yeah, so provided she's a young 50-year-old fit patient with small renal mass, her chance of having a complete sparing of the transferring surgery is probably easily amenable with whichever approach she would opt in. So I would go for partial nephrectomy in her case.
Okay. If I could go to Tilly here. Tilly, in your presentation, you spoke about the slight lack of clarity on the impact of renal function preservation and overall survival. I think Von Poppel's paper spoke about it. What are your views in this situation, Tilly?
Well, of course, all T1 options would be possible. However, I would discuss with the patient about surgical trials which had shown partial nephrectomy being with very good survival after tumor resections, and also kidney function preservations. Also, there would be question what kind of comorbidities or what was the kidney function before operation. But as I remember, this patient had everything in normal values. So
correct.
Yeah. Or
would you have
preferably partial nephrectomy because of the age.
Fantastic. Patricia?
Yeah, well, I think I would discuss with the patient partial nephrectomy or focal therapy, so ablation, but keeping in mind that there's perhaps a higher chance of local recurrence. So I think that would be the discussion, or active surveillance, of course, but this is a quite young lady, healthy, so normally people go for active treatment, and then this would be the two options to consider with the biopsy up front or not.
Okay, excellent. Raghunath, what would your views on this be, Raghunath?
Yeah, she's 50 years and a fit lady with an exophytic mass less than 4 centimeters. Definitely, I prefer to go for partial nephrectomy if it is proven to be RCC. And I would, to have all the options, I would convince probably patient to go for robotic if provision is there and if she's willing.
Sure. Fantastic. So we did provide perform robotic partial nephrectomy on it, and histologically this was renal cancer. And I think the view we take at the Freeman is that if the patient's quite fit, our view is to preserve renal function and to remove the tumor away. And the reasons we have is, regardless of what level 1 evidence is a lot of retrospective data which would suggest that renal function preservation has an impact on overall survival. In terms of our choice of treatment, I think again, the lack of level 1 evidence is accepted, but our feeling is that the local recurrence rates are low with partial nephrectomy. And so for someone who's young and fit, with no competing illnesses and a very good anticipated life expectancy, this would be our treatment of choice. Would anyone have anything to add on to that?
Bhavan, I have a comment to make. We recently collected pathological data from small renal masses from various centers in India. It is a histopathology of post-partial nephrectomy. The histology was benign in less than 2% of our cases in India. So many postgraduates from India are viewing this. So as against EU guidelines and Western literature of 20% benign small renal masses, here post-partial nephrectomy, we have less than 2%. That's very important. We don't know whether to do biopsy for these patients or not, because the incidence of benign tumors in our small renal masses post-surgery is less than 2%. Of course, if we are not yet published, we are going to publish this. Thank you.
Yeah, we're finding the same with our ablation patients, actually.
Okay. Anything else anybody would like to add? Okay, I'll go on to the next patient. So this patient's slightly different. This is a 72-year-old lady. She again presented very similarly. She's got ischemic heart disease, AF, COPD, and diabetes mellitus. Despite all of this, you'd still think that she's got a reasonable life expectancy. She's got an ECOG status of 1, but she's otherwise okay. And her scans look similar as well. So it's not the best scan, cross-sectional image, but I'll show you another image. This is okay. It's a small renal mass. What do you think about this?
First of all, I'd like to be certain there's no fat right next to that, and this isn't a collision tumour of some sort. But no, assuming it is as it looks, there's a small enhancing renal mass. Yeah, it could be a small RCC, or as we said, less likely something benign.
Okay. And in this situation, I'll come to Patricia again. This time the tumor is 1.8 centimeters. It's relatively small. She is not the fittest, but she's not terrible. She's got intermediate fitness levels. Would you biopsy this lesion?
Well, again, I should discuss with the patient. Probably advise to go for active surveillance and see how the tumor is doing. If it's not growing that fast, you can consider just to go for active surveillance, because she has a high comorbidity score, Charles' score, I think something like 5 or 6. So I would have a good talk with her.
Okay. I just want to highlight to our audience that apart from the previous options, I've also added SABER here. And Patricia in her presentation spoke about this as an option as well. Anyone else think that we should be doing anything apart from active surveillance in this lady?
I would like to make a comment just about, I think the decision is good, but that we once had an audit of biopsies done by the radiologists at the Royal Free, and they found that if a lesion was under 2 centimeters in size, that the diagnostic yield was around 60%. So it drops really to the one in the literature. And I remember that at the EAU, once there was a presentation, it was a retrospective series of patients who were 70 years and older, and lesions of 2 centimeters in size maximum. And none of those patients ever died of one of these lesions. So I think these are both very good arguments to keep the tumor under observation even without a biopsy.
Excellent. That's exactly what we did. We did monitor this patient and we organized a CT scan in 6 months' time. This is the same lesion in a coronal view. It's now increased to 2.2 centimeters. Same options again. What would you do in this situation? Phil, would you consider this patient for ablation?
Yeah, I would. If that's what she wanted, I would microwave ablate that. We'd just do that under sedation, and it would be done in about 50 minutes of CT time, and she'd be home the same day.
Patricia?
Well, I think it's only like 4 millimeters has been growing. So sizes of the CT scan are 3 millimeters. So is it really growing that fast? I would just go for active surveillance for another couple of months and see. But if she wants to go for focal therapy or SABER, it's good, of course.
Axel?
Yes, I would agree. I mean, both, again, you might argue here, you discuss it with the patient. If she's very anxious, then I think there's nothing wrong with proceeding to ablation or SABER if that's available. But let's remind us that the data on SABER, they're probably good. They're good systematic reviews. But there's also an equally good argument to just keep it under observation. But if the patient does not tolerate that, then it would be good to go to active treatment.
Just bear in mind when you... So I was just going to say, talking about SABER again, bear in mind when you're looking at the data on SABER, that they consider stable disease a success. We wouldn't. So you're not comparing like with like if you're comparing SABER with ablation.
So in this patient, we discussed options. She was a bit anxious, and we therefore proceeded with ablation. And now I'd like to put the final case on for the day. This is an 83-year-old lady who presents, again, had some loin pain and hematuria after a fall. She is not very fit. Apart from all the comorbidities outlined above, she's also on warfarin, and performance statuses too. She had a CT done because of the fall to see if there's any sinister cause for a bleeding or anything that requires being imminently addressed. And again, a similar mass was found. In this situation, would anybody biopsy her? I think we all agree that we wouldn't biopsy her. Anyone would consider any form of treatment in her? So I think all of us would
agree with
all of us.
Yes.
Yeah, so in this situation, we don't even, what we would say, we don't even do active surveillance. Our practice, we leave this patient alone. We don't image her any further and only treat her if she has any symptoms, and which may never ever happen in her lifetime. Does anyone else have any different opinion to this in the panel?
I think leave alone is a very good option. Sometimes it's very difficult to convince the patient, although they're 83 with all the comorbidities, to leave them alone and to dismiss them. And then the discussion is, well, I find it's very difficult, these kind of talks. The whole family is there. And then, yeah, I don't know how the others experience that, but I think it's sometimes difficult.
I agree, Patricia. These are tricky. The discussion with patients can be quite difficult. And sometimes you're having to treat the patient's anxiety. Just having some disturbance there. I think that sometimes having to treat the patient's anxiety rather than the mass, but it is a difficult situation, I accept. Anybody else with any other views on this?
Just to add to the discussion, if the similar situation was present in a 72-year-old lady who is already, suppose she was on a warfarin protocol, what would have been the anticoagulation strategy peri-procedure for ablation? As in, I just want to know this from Philip or someone.
Well, it depends on what the patient was on warfarin for and whether it's safe to stop it. But assuming it was something fairly critical, convert to heparin, stop the heparin, ablate them, restart the heparin the following day.
Right.
And just to add on to that, this is one of the clinical scenarios, Ashwin, where we think SABER may be an option if we can't stop the anticoagulation and if the patient's of intermediate fitness and with a reasonable life expectancy. This is the kind of situation you may want to consider a SABER in. That means that there's no form of invasion into the patient. Okay. So I think that's all our cases for the day. And that's us concluding with our teaching program today. I'm very grateful to all our panelists for participating, and I know you guys are really busy. So thank you so much for contributing to the Renal Cancer Teaching Day.